Randale, is it better? Okay,
Yes, Doc.
okay. Gotcha. So we ended with this one, correct? 119, correct? All right. So TCA cycle, also known as the tricarboxylic acid cycle, with Krebs cycle or citric acid cycle as important pathway for energy, because we all know that glucose it's all about energy. Now, ATP is charged from it's a charged form of energy. When ATP imparts energy, it is converted to ADP, adenosine diphosphate, which is ADP recharged by mitochondria, recycling ADP into ATP every 50 seconds. So this is how it works. Now, for the monophosphate shunt, which is not efficient as the energy source, yes, thank you. Yeah, later, thank you. Okay, which is about 60 to 70% of glucose used. So that's your pentose phosphate pathway. So other term for hexose monophosphate shunt is pentose phosphate pathway, which is limited recycling of glucose about 85%, which is used or catabolized or utilized to lactate. Okay? So, the effects of hypoxia. Okay. Okay, the effects of hypoxia and anoxia. When there is hypoxia, there's less oxygen. When there's anoxia, there's absence of oxygen. So if you can see here, based on, wait up, it's blocking, right? There you go, even better. All right, is that clear? All right. So for hypoxia, which is just decrease in oxygen, there is a decrease in ATP production. Correct? Are you still hearing me? Randale, please confirm.
Yes, Doc.
All right, good. And then there's increase in lactate production because again, when there is lack of oxygen, lactate goes up. Correct? Yeah, that's one thing we understand. When there is a decrease or there's no oxygen, problem with oxygen, lactate will definitely increase. That's why you would notice in hypoxia and anoxia, both lactate production increases. Though for hypoxia, there's a decrease in ATP production, in anoxia, there is increase in ATP production. So there's a difference. But when it comes to stored glycogen, of course, you would notice the EM pathway goes down, lactate dehydrogenase goes down, glucose level goes down. When it comes to anoxia, you would see, of course, when there is no oxygen, if there's no oxygen, then you are already looking at decrease in TCA cycle to the point of stopping. And then there's decrease in lactate dehydrogenase and glucose flux and utilization is your um, effect that goes down. Okay, it goes down. So lactic acid, for those who are working out, we are always familiar with lactic acid. So this is not metabolized by your cornea, removed by diffusion into aqueous humor. Accumulation results in epithelial and stromal edema. So of course, when there is, again, based on anoxia or hypoxia, the next thing that you're looking at is inflammation. So hypoxia doubles lactic acid concentration, resulting in an osmotic gradient. Okay, So corneal transparency of stroma is about 90%, can transmit incident light. That's why we need the cornea to be transparent to transmit light. Now, potentially a non-transparent layer, fibrils with an index of 1.47. Good to know. Don't worry about it. Corneal swelling, though. Lactate and metabolite accumulation, creating osmotic gradient, causes water imbibition. That's why when there's water imbibition, automatically it swells. Right, Randale? It's just like, I don't know if you have a toy that when you soak in water, it swells. Do you have that? Do you know that? Like a gel or some sort that when you soak in water, it will absorb everything and it gets bigger. That's how the swelling goes, correct? All right, so you would notice the hydrophilicity of the gags, which we already know, causes a natural water imbibition. And the swelling during sleep is due to 50% hypoxia. So, Patricia, when you sleep, there's already a decrease of 50% right away. Okay? And the 50% because there's no atmosphere, correct? Because you get oxygen from where? Oh, Andre, you have a setup. Nice to see you. Good, good, good. All right. So, of course, it's from the atmosphere, right? So, when your eyes are closed, automatically, that's about 50% right away. Correct? Are we clear on that? Is that yes or not so clear? Are we clear? No? Can you hear me, by the way? All right, very good. So we're clear? All right. So lower tier osmolarity, when you say osmolarity, we are talking about, um, let's put it this way to make it easier. All right. For example, okay. So you would notice that there's a lot of assuming sodium in this area. The tears or the tear film or the aqueous or the water content will be absorbed just like similar to being thirsty, right? When you eat chips like maybe Pringles, Lay's, and what have you, the first thing that will happen to you, Randall, is get what happens to you when you eat? Yeah, give it to me. My son said, when you eat this, what's this?
Pringles.
Pringles. So when you eat Pringles, what happens? Randall,
I'll be thirsty, Doc.
very good. And you know why? Because there's increase in sodium, right? So that is the osmolarity component, wherein it should be isotonic. There should be equal. But if there's an increase in sodium, you already know that somewhere it will get its source of wherever it can get the water, right? So in the process, you will have imbalance, correct? All right. Which is, again, logical. Also, with the increase of temperature and humidity, you already know that. Corneal swelling affects change in refractive index. That's why you would notice when there's swelling, your vision becomes, it starts with letter B.
Blurry.
Blurry. Very good, Randale. Blurry. causing Sattler's veil. What's Sattler's veil? You would notice in weddings, the ladies or the bride will wear a veil and they would walk with veil on. Correct, Randall? Do you ever wonder what they see under the veil?
Maybe it's blurry because of the veil.
Correct, not clear because there's something in front of their eyes, but they can see through, right? You can still see something. It's just that it's not going to be clear, right? All right, that is your Sattler's veil. And also some halos. Okay, those are the effects. So again, Randall, what are the effects of swelling?
It can cause blurry of vision, like Sattler's
Ah,
veil.
correct. Very good, very good. Endothelial pump, we discussed this already, right? Each cell pumps owns volume about every 5 minutes. Or in there's an active transport, wherein, as I've mentioned, there is sodium, which is part, and then there's potassium in adenosine triphosphate, which is dependent on the pump of the endothelium. Okay? Now, sodium ions move between the stroma and aqueous humor, then water follows passively. As I, based on my drawing, that's exactly what I just explained. All right? So there will be sodium first, and then follows the water, right? Just like when you eat Pringles, comes after that is thirsty, right? Then you'd end up drinking water, correct? All right, so there is bicarbonate from stroma into the aqueous humor is about equal to sodium ion outflow. Wherein we want it to be isotonic. Now, bicarbonate transport is electroneutral. Only sodium ions pumped into the cornea produce potential difference, thus creating osmolarity. Okay, now active process drives chloride into the cornea from the tears and sodium into the tears. Epithelial pH regulated by basal cell sodium. So sodium in, hydrogen out. So that's how it works when it comes to the epithelial pump. So this is how it looks like. Okay, so this is more of understanding how the ABCDE works. So you can appreciate your cornea more. So your cornea is really complex. It does a lot of things. And every layer has a purpose. And those for purpose, of course, together with its function, we get to understand it uh, deeply. Okay, so relatively inactive except for keratocytes metabolism. Lactate per se has no effect on corneal function. Factors influencing corneal thickness. Why is your cornea thick? Or why does it thicken? Of course, number one, it differs because of individual variation. Like Randall, how tall are you?
5'7" Todo.
You're 5'7". I am 5'9". Just kidding. So from the get-go, we are different, correct? All right. Tear evaporation, it depends on your environment. So if you are in a place where evaporation is experienced, then you know that there will be some morphologic change, thus creating the corneal thickness, and some osmotic response, such as hypertonic thinning. Now, there's reflex tearing, such as the hypotonic, and of course, as I mentioned last time, did I mention that when you wear contact lenses, you are actually subjecting your patient to hypoxia? Did I say that? Randall? Or to the other section? I said that? Yes, I said that. There you go. And that induces thickening. Okay? So now sa osmolality against osmolality. So what is the difference here? So the liter, which is osmolality, is about 294. So I have here whenever you talk about liter. So that's 1 liter. So per liter, you are talking about osmolality because it's liter, right? Okay. So initial, you have decreased tear osmolality. We're talking about lality, okay? Not larity. Okay, there's a difference between osmolarity and osmolality. Okay, so whenever we're talking about lality, we're talking about volume in liter of water, right? So increased tear osmolality affects evaporation, return to pre-lens value after wearing contact lens. So when you wear contact lens, of course, it will alter your tear film osmolality. So corneal integrity requires oxygen. As we all know, oxygen is the number one most important metabolite, correct? That's why there's a need for oxygen for us to function well, correct? So just understand, even with the cornea, it will also function well when there is oxygen, right? Do you think, Randall, you can work without oxygen?
Hindi po, Doc.
Exactly. Now, 13.1 to prevent suppression of epithelial mitosis, 8% to prevent sensitivity loss, and 5% to prevent glycogen depletion. So that's the requirement. Meaning to say, if you are to wear contact lens, make sure that you still have oxygen. That there should be at least that utilization of oxygen. Because when you wear contact lenses, automatically there is a depletion, correct? And that causes, of course, in the process, hypoxia. And as I've said, no matter how permeable or transmissible is your contact lens material, hypoxia is still a an existing problem, right? Now, corneal integrity also requires carbon dioxide elimination. Of course, we all know inhale, exhale. We inhale oxygen, we exhale carbon dioxide. So we have to get rid of carbon dioxide. There must be some carbon dioxide elimination. We understand this because, sometimes, Randall, you release gas, correct? Do you release gas?
Yes, Doc.
Okay, so therefore you're human, right? Because you release gas. Okay, now glucose is also important, of course, as main source. We already know that. Carbon dioxide permeability. When it comes to hydrogel, about this is the data that was given based on their research. If you wear hydrogel, so hydrogel is a type of material under soft contact lenses, which requires, of course, also oxygen. So there's 21 times more than oxygen required, and RGP 7 times more than the oxygen as per requirement, and for cornea 7 times more than oxygen is your carbon dioxide permeability. Do you understand that? Why? Remember, if you inhale, you need to what?
Exhale po.
Exhale. Very good, very good. Of course, we understand pH, right? pH 7 is normal, right? I mean, we've learned this even during our um, preparatory, or even in high school, or even elementary, right? We already learned about the pH. Okay, we're in pH of tears in open eye is 7.34 with a tolerance of 6.8. That's why eye drops are outside the pH range will sting. Correct? All right. Meaning to say it's either acidic or basic or alkaline, right? There's only two anyways, correct? That's why you always understand the pH 7. It's just like saying I'm under the neutral. Anything that is below 44 is flat. Everything above 44 is steep, correct? There you go. So it's the same thing. Same. Understand that this is your pH. Now, age-related corneal changes anatomically. So, Randale, maybe when you see me this Saturday, check how many of these age-related corneal changes do I present. Do you think you'll see a lot from me?
I think I will see all of it, Doc.
Oh my gosh, you're so mean.
Joke lang.
Okay, all right. So I have arcosinilis. What is arcosinilis? It's a
Yung,
ring that is white around, correct? Because of fat deposits, correct? Then we have white limbal girdle of Vogt. There's also a decreased nerve elements in cornea and eyelid, meaning to say we are less sensitive, right? Correct, Randall? And there's this dystrophy and degeneration. As a matter of fact, one thing that you know when you're getting old, there are a lot of degeneration that is happening, right? Okay. Most of the elders, you would notice once you check their conjunctiva or when you check their sclera, you might be observing some of the pinguecula and some of pterygium, correct? Especially those who are exposed to what?
to dirt and
Huh?
sunlight.
Sorry? Sun. Very good. Because pinguecula and pterygium can also be um, maybe you would notice with the fisherman or some elder people exposed to the sun having pinguecula and pterygium. Now, against the rule, astigmatism. Why against the rule? From a with the rule to against the rule. Of course, we know that the changes, we know the sagging and all of this constant blinking, creating that against the rule. Correct? Okay. Now, decreased transparency. That's why you would notice old, well, I don't want to use that because I'm already old, Randall. Like advancing people, if you notice the transparency of their cornea is not as good as a baby's, right? So you can see like there's already like translucency, correct? Like kind of whitish. Yeah, I don't know if you were able to observe. If you are going to have your clinic, you might encounter some patients having that from your geriatrics, right? So you would see that. There's also peripheral thinning, endothelial cell loss, and polymegathism. Okay, another is increase in permeability of limbal vasculature. That's why some of us would have translucent cornea because of that. Decrease in endothelial pump activity, lacking, of course, the exchange of oxygen, carbon dioxide, decrease in metabolic activity, such as you already know that when it comes to the ATP, ADP, it's reducing its activity. thus increasing in refractive index, thus increasing in visibility of nerves. That's why um, most of us would not have the same clarity of vision as young ones, correct? That's why most of the elderly would complain of blurring of vision. And this is an age related condition, correct? All right. So far, so good. Questions? Randall, any questions there? Do you see anyone raising their hands? No one?
No one po.
All right. Thanks, Randall. Okay, let's talk more on the tear function. Of course, optical. What about optical that we know? Because, of course, the tears make the surface smooth. And when the surface is smooth, refraction is good, correct? Now, physiologic, of course, the function of it, and the bactericidal and bacteriostatic. What's the difference between the two?
Bactericidal po, namamatay yung bacteria. Pero bacteriostatic, hindi lang sila makagalaw. Para silang disabled or
Uh,
normal.
all right. So based on the wordings, you can see there, cidal. Cidal is, of course, killing microorganism. Again, static. Static means stop. So what does it stop? The growth of microorganism. Okay? Correct? All right. Then, of course, for metabolic purposes and protective, as such, flushing of debris. That's why you would notice when you have a speck in your eye, all of a sudden you have to produce a lot of tears, correct? To flush those foreign objects, correct? All right. That's why we need tears. Tear composition, you have three layered structure. Again, we already know the mal or the lamb from outer to inner, inner to outer, right? And some believe that tears should be regarded as two layers, which I mentioned the last time too. So this is your cross section, wherein we said last time, right? There's that lipid layer, and the second layer is a combination of your aqueous mucus, right? Correct? So you can boil it into two. But if you want to divide it into three, you have your lamb. So tear, which is divided into three, coming from inside out, first you have mucus layer or the mucin layer, which is 0.02 to zero point zero 0.05 thick micron. So this is extremely hydrophilic. That's why, remember, I said this. It creates a hydrophobic cornea into a hydrophilic cornea. And that is the responsibility of your mucus layer, correct? Which is adhesion of that cornea. Can you imagine? Without the mucus layer, the aqueous layer will not adhere to the cornea because cornea is hydrophobic, right? So that's why we have the mucus layer. Now, greatly enhances epithelial wettability, microvilli and microplicae, which we understand is like your towel, maintains stability of tear film, secreted by the goblet cells of conjunctiva, and some may come from the lacrimal gland. But mostly, it's the goblet cells. Remember MG? We're still good? Okay. Now, the aqueous layer, which is the bulk of tears, about 7 micron thickness, the only layer involved in true tear flow. So when we're talking about the true tear flow, you can only have that with the aqueous layer. Now, the vehicle for most of the tears component is, of course, the aqueous. You have there the antibacterial and uh, uh, bacteriostatic, nutrients, uh, lubrication, name it. It's under the aqueous layer. transfer medium from oxygen to carbon dioxide, produced by lacrimal glands and accessory lacrimal glands of Wolfram and Cross. Now, the lipid layer, which is the outermost layer, is thin, about zero point 0.1 micron. So main function is anti-evaporative, which prevents tear fluid to overflow, anchored at the orifice of meibomian gland. Now, compressed and thickened during blinking. So that's why you wanna express the meibom. You might want to squeeze it, right, for the meibom to come out. So compressed and thickened during blinking drags aqueous fluid, producing increased film thickness that is being spread across every time you blink. That's why, Randall, you might want to practice force blinking. Whenever you do force blinking, you are producing that oil, right? Like that. Force it. Do it again. One more time. There you go. You are not seeing it because that's most likely microscopic, right? You cannot see it, but you are actually benefiting from the meibomian every single time you force blink it, right? Because comes out the oily layer, correct? Now, um, again, this is mainly secreted by the meibomian gland, some produced by the Zeiss gland, and contains dissolved lipid and mucus. Now, the tear properties is about 98.2 water, as we all know, because our body is composed of mostly water too. So normal osmolality again is the liter, right? About 294 to 334. Osmolality is flow rate dependent. Decreased osmolality following eye closure, wherein it reduces evaporation, of course. With some glucose, mainly from the aqueous humor, because we know that the producer of glucose is your aqueous humor, correct? Are you still there, guys? Because I don't see Randall anymore. And I don't see Andre anymore. Is it dinner time? What time is it? Anissa is there. Is it already dinner time? Time check. 7:30. Is it 7:30? Yep, 7:30. Our class is still 8, correct? All right, so let's go. Next, of course, the bactericidal and bacteriostatic component because of the lysozyme, the lactoferrin, and the beta-lysine. So in addition to sodium, and we have, of course, the potassium, hydrochloric, and some amino acids, urea and lactate and pyruvate. So that's your tier properties, which is good to know. Hi, Rika. Say hi to your dad. Did your dad get the thing I gave? Yes?
Yes po, Dok, nakuha niya po.
Does he
Hindi
like
pa
it?
po.
He doesn't like it. Huh? He doesn't like it?
Hindi ko pa sure if nakita niya na po. Pero, sinend
Okay.
ko po sa kanya yung picture eh. Wala pa po kasi siya sa house.
Oh, okay. Thank you. All right. Tier dimension. Volume is 6.5 to 8 milliliter. Right. Yes. Or microliter, sorry. Flow rate is 0.6 microliter per minute. Turnover rate 16% per minute. So there's a turnover, meaning to say again, we understand that shedding, right? Daily production controversial. They say it's a range from 1 to 15 grams. Okay. So they couldn't really like say that's why it's a range. So it's like saying it's somewhere there. Now, tear secretion rate, stimuli, we have the psychogenic and the sensory. So previous division, you have the basal and the reflex. When you say basal, that is Andre, the basal, whenever you say basal, that's the one that we are always measuring. We are not measuring reflex. I say this again, Randale. We are not measuring the reflex. The only thing we are measuring is the basal, okay, or the base tier, right? The basic tiers. That's the only thing that we wanna, whenever we wanna qualify or quantify, we are always looking at the basal. All right? Because reflex, on the other hand, like when you do your Shermer, that's why Shermer or your tear strip that you use is inducing a reflex tears. You know why? Because it's a foreign body, right? And once you put it there to the point of it's so rough that it creates reflex tears, correct? All right, thanks, Anissa. So tear film stability, time taken for the tear film to break. We remember, how do you come up with a breakup? Tear breakup? What causes tear breakup? Do you remember last few slides before this?
Oil
How
plus
do you
kerosene admixture.
Very good, Joyce. Very good, Joyce. The admixture, right? Very good. Very good. Wonderful. Good, good, good. By the way, who's jotting the scores for recitation? Please do so. Okay. So breakup. Let's talk about breakup time. So under breakup time, of course, we have two. The tear breakup time based on the invasive and the non-invasive. So you have your it butt and the knit butt. So you make use of sodium fluorescein. Therefore, this is already an invasive way because you make use of um, another channel, like from basic, like non-invasive, which is you just check the reflex once it's already distorted, or with the use of a topographer with a tear analyzer without placing anything. So that's your non-invasive. But once you make use of stuff such as sodium fluorescein, those are, or rose bengal, and what have you, those are invasive. So tear film monitored under blue light because of the fluorescein. That's why there's fluorescein light, because it will turn into green or yellow, right? Correct? With the use of black light. So record the occurrence of the dry spot. So the dry spot is like you would ask the patient, blink once, blink twice, blink three times, and open your eye, and then hold. And as you hold, you would see slowly they would create there will be some of those spots, and those spots represent breakup. Okay, clear so far? We'll do all of that. Repeat measurement required. It depends. Again, abnormal eyes may not form a complete film. So how do we say that it is abnormal? When it is lesser than 10 seconds, it is abnormal, correct? So what is considered normal is 15 to 45 seconds. So the longer the breakup, the better the condition of your ocular surface, correct? Meaning to say you have enough tears and it's not drying up quickly, correct? All right. So far we're good? We're clear? All right. Very good. So this is how it looks like. Your admixture, of course. You have the breakup, creating dry spot. So the non-invasive, which is the most effective, the most consistent, and the most reliable. So meaning to say, Randale, Rika, if you are to assess the tears, we strongly suggest, or internationally, all the practitioners would always recommend to use the non-invasive way. Okay. Why? Because you don't want to alter the environment of the tears, right? Not creating reflex tears, not jeopardizing your basal tears. So non-invasive is the most effective. Okay. So there you go. You see that there's a dry spot formation. And wetting the cornea, of course, we have your glycocalyx, which binds mucus layer. That's why some of the ingredients or active ingredients of the artificial tear contain glycocalyx. There are some brands that carries that glycocalyx as an active ingredient. Now, surface will wet again with surface tension. We understand that the surface tension is like when you blink, 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 and then there's a surface tension. Okay? And then after that, we are looking at how this will change and will depend and is reduced by the lipid layer and palpebral fissure width, right? Now, tear function test. What are the tear function tests? So you have your breakup test, the non-invasive breakup test, you have your Schirmer test, you have your fluorophotometry, you have the phenol red thread test, rose bengal staining, tear film osmolality test, and those are the tests used to measure your tears, both qualitatively and quantitatively. So what's the difference between qualitative and quantitative? Is there a difference?
Qualitative po ay subjective at ang quantitative naman po ay objective. Nagbilang ng 1, 2, 3. Parang ganun po.
Okay, whenever you say the quality of tears, it's like saying, what is the quality of an Adidas shoes? Okay? Against the quantity, how many shoes were sold and why is it sold? Do you understand what I'm saying? My example? When you say quality, it's like quality of something. We're talking about how nice is this. So how nice is your tears when it comes to the lipid, aqueous, and mucin layer? Is it good? Is the ratio still good? To compare with quantity. Quantity is more of how much. Yeah? Correct? All right. Very good. Very good. Now, Schirmer test, which is, are you familiar with Schirmer? Have you done this? Good, good, good. All right. So we already know what it is, which is inserted into the lower fornix, creating reflex tears, correct? Most of the time, whenever you do this, this creates a reflex tears. And whenever there's a reflex tears, we will not include and record a reflex tears because that's not what we're looking for, correct? Is that correct? We need the basic tears. All right? Anyways, that's why some of the practitioners are not using Schirmer test anymore because of that. Anyways, I'm just uh, interjecting some of those things that we learn from the practice outside. Okay. The real practice. So this is how it looks like. Fluorophotometry, which is used to measure the tear flow rates. So obviously, this is a more sophisticated kind of thing back in the days, but now We don't have much of that. You have the phenol red, which is a lot easier because it's not as thick as your shimmer, your tear strip. This is thinner because it's just a thread. So you would notice it measures the tears when there's a red indicator. So it means up to where will it end. So if it is shorter, it means you have problem with tears. There's tear deficiency, correct? So there's decreased lacrimation produces cell degeneration. So rose bengal stains the resulting necrotic cells. So the necrotic cells, as you can see here, so we know already the dead cells, right? The necrotic dead, all right? Tear protein low concentration. You have albumin, prealbumin, lysozyme, lactoferrin, transferrin. It's good to know, but don't worry about it. That's not the. This is more of the good to know. Mainly secretory immunoglobulin, of course. Uh, Again, this is just on the good to know. But closure, those most important thing that you need to understand is the closure of the eyelid, contraction of the orbicularis oculi or oculi muscle. So there's no reciprocal innervation between the orbicularis oculi and the levator palpebrae superioris muscle or the LPS. Now the innervation is by facial nerve, and of course we already know how it closes from temporal to nasal, just like a zipper. So rate 15 blinks per minute, duration 0.3. Globe moves up and down towards the nose and backward. Forced closure involves the orbicularis oculi and the molars muscles. Sleep tonic stimulation of the orbicularis oculi and the inhibition of the LPS. Okay, contraction of levator palpebral superioris muscle is necessary for the eye opening. Some assistance from the molars muscle, and the main innervation is the oculomotor. So blinking, again, lower lid hardly moves because which reptile or which animal wherein lower lid is more than the upper lid when it comes to movement? Is it an alligator? Is it a snake? Is it a lizard? Are you aware of that? Wherein they close from down to up? Because we close our eyes from up to down, correct? That's why your upper lid closes more than your lower lid, right? Right? Because we're human. Okay, so there is spontaneous blinking usually responds to corneal dryness, irritants, anxiety, sustained. Like I think I have demonstrated this in last Saturday, or in this is a reflex. Blinking is a reflex to protect us, of course. Relatively, humidity is not a blink stimulus because it's just humidity, right? Blink reflexes, facial nerve nucleus connects with superior colliculus, trigeminal nucleus in the superior olive. Now we also have the optic reflex, the sensory reflex, the aura palpebral, and the cochlea palpebral reflex, stretching or striking reflex, and the psychogenic reaction. These are your blink reflexes. So if I am to ask you what are the different blink reflexes, so you already have 1, 2, 3, 4, 5, 6. Now eyelids and tears. Your lid spreads tears. That's why, Randall, I just ask you to force it to blink because it will spread tears, correct? Resurfacing with the mucus later increase tear film stability. Blinking pumps tears into the nose via puncta or punctae Lid closure compresses lid. Lipid tear layer. Eye opening drags aqueous phase of tears. Thickening tear film. Lid acts on lacrimal gland and gravity moves tear over cornea. Lid muscle action has a role in accessory lacrimal gland output. Okay, now protection is the main one of the main function of your eyelid is to protect you from what? Threat, bright light, foreign bodies, desiccation, visual stimulation. Are all these familiar? All of these are familiar to you, right? Because you experience that. You close your eyes when there's threat, bright light, foreign body, desiccation because it hurts, and visual stimulation. Correct? All right. So, if I am to give this quiz, you already know. Please answer. One is
Eyelid.
Eyelid.
eyelid. Two is tears. Okay. Three is
Cornea.
cornea. And four? What's four? You don't know.
Conjunctiva, Doc.
Hey. Very good. How about this one? What's this? It's the ABCDE, bro. What is
A
that?
is epithelium, B is the stroma, and C is the endothelium.
Okay. Very good, very good, very good, very good. Very good. And how about this? 5. What is
5 is
5?
the limbus.
Very good. Ha? Galing, ha? What is 7?
Terminal blood vessels.
You're looking at your notes, ha?
Milk vessel po.
6. Almost done, baby. Actually, in a little while. Yeah. All right. How about this one? A. B. C. A, B, C, D, E. This is your A, B, C, D, E, guys. Have you forgotten? A for epithelium, B for Bowman, C, stroma. You have your decime and your endothelium. Is it not? Randall?
Tama po,
Oh,
Doc.
okay. Good, 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 good. How about this?
Layers of
This
epithelium.
is
There you go. Which is? Where's the squamous?
squamous is letter A.
All right.
B is the wing cell, and C is the basal cell.
Basal. There you go. Very good. All right. Last. What is this? It starts with letter F.
Fibroblast.
Oh, there you go. All right. Thank you very much, guys. Thank you. I'll see you on Wednesday, correct? Okay, we have a new topic. All right. Thank you, guys. Any questions so far? All right. You may leave. Randolph, I'll stay. Okay? All right. Thank you, guys. Thank you so much.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank
Enjoy
you,
the
Doc.
Thank you po, Doc.
Thank you po,
Thank you
Doc.
po. Thank you po.
Thank you, Doc.